This is the second part to the webinars covering calcium and phosphate homeostasis. In this webinar, we'll discuss the hormonal regulation, the role of vitamin D, parathyroid hormone, and calcitonin. So as an overview, we're going to be discussing what we refer to as calciotropic hormones. That's just a general term for parathyroid hormone, vitamin D, and calcitonin because they're referred to as calciotropic. That term tropic means changing because of or responding to something. So these things respond to changes in calcium levels. I've put parathyroid and vitamin D together for a reason, because they have similar roles in regards to maintaining calcium. Their both job is to try to get blood calcium levels back up. Calcitonin is left by itself because it will have the opposite effects. Now their targets, which we had discussed in the previous webinar, was the bones, the GI tract, or the kidneys. So somehow they may affect storage, because that's where we store calcium. They may affect the absorption by affecting various proteins that are involved in transport of calcium across the GI tract, or they may affect kidneys. And I put excretion because if you don't absorb it, in this case I would say if you don't reabsorb it, it will be excreted. So somehow they're going to affect one or more of the others. Some are going to, when we talk about certain ones, we'll say this is its primary effect. And when really when we talk about vitamin D's major effect would be within the GI tract. So let's start with vitamin D. Now vitamin D is really a hormone. It's like, oh, it's a vitamin. In reality, it is a hormone. Now when I say vitamin D, I am pretty much referring to the active form of vitamin D, which is called calcitriol. Now this here, 125 dihydroxycholcalciferol, is calcitriol. calcitriol. That is the active form of vitamin D. But to get to that point, there's a number of steps involved. We can synthesize that within our body as long as we have certain events that take place. Ultimately, calcitriol is derived from cholesterol. And cholesterol is converted to the 7-dehydrocholesterol in the liver. Okay, you don't have to remember that step. But in the skin, in response to UV radiation, we're going to convert that to vitamin D3, it's cholecalciferol. That is not active vitamin D, but that step is needed, though, in eventually making vitamin D. That usually is the number one reason for someone being deficient in vitamin D is lack of UV radiation. They don't get enough sunlight. But that vitamin D3 will then be converted to 25-hydroxycholcalciferol in the liver. We have a certain amount of that hanging out in the liver. That is can come back, if this gets too high, come back and inhibit the step here. The kind of prevents excessive vitamin D if your intake is too high. Now we do store this form in your liver for many months, but we're still not active. In the kidney, this 25-hydroxycholcalciferol will be converted to 125-dihydroxycholcalciferol using an enzyme called 1-alpha hydroxylase. And this is favored under conditions where there's lower phosphate levels. If phosphate levels are too high, you'll convert it to an inactive form. So what did that 1-alpha hydroxylase do? Well, it added a hydroxyl group to carbon 1 on the that 25-hydroxycholcalciferol. So you end up with 1,25-dihydroxycholcalciferol. That enzyme, 1-alpha hydroxylase, happens to be stimulated, become more active if parathyroid hormone is around. So we're already starting to show you a link between more than one hormone involved in calcium maintenance. So what you end up with is this calcitriol. This calcitriol, one of the main actions is it affects the ability to transport calcium across the GI tract. So it increases the calcium pumps and calcium binding proteins, which increases the intestinal reabsorption of calcium. Well, so, big picture. In order to have this active form of vitamin D, you need to have a number of organ systems involved. The steps involved in the synthesis involve the liver, the skin, and the kidney. The active form of vitamin D is synthesized within the kidney. So you need to have proper kidney function and lower phosphate levels to make the active form of vitamin D. Also, having parathyroid hormone around further increases the activation of vitamin D. Now, a lot of people hear about vitamin D being put in foods. Well, the vitamin D they actually supplement in foods is this vitamin D3, because usually the number one step that people have a problem with is they don't get enough exposure to sunlight, so it's this step is limiting for them. So foods are supplemented, like milk, some of your fortified cereals. In England, I know they put this into butter. This is what the food has been fortified with, because in most cases, everything else is functioning properly. So this is, if they're going to supplement, they supplement with this, it's the vitamin D3. Now when you, well, let's just mention something first before we move on, because this gets, a lot of people are interested in it. What do you need, how much sun exposure do you need to make this vitamin D3? As I said, that's usually the limiting factor. Well, it depends on your pigmentation of your skin. If you're very dark complected, the dark complexion protects you from UV radiation. But as a result of it, you're more likely to have problems being able to convert that 7-dehydrocholesterol to vitamin D3. It depends on how much skin is exposed, how long is exposed, the time of year, where you're located, because the latitudes where you're from determines the intensity of the sun exposure. So in higher latitudes, like say you start going Boston, New York, Canada, there's insufficient UV radiation to make vitamin D between usually months of November and February. So during the spring, summer, and fall, it's okay, but they say all you need is about 5 to 15 minutes that it's necessary. But the hardest time is when certain times of the year they're not going to be able to get enough exposure to it. And vitamin D deficiency is extremely common now. My mother, who worked in a clinical lab, had said that would be hundreds of requests going across her desk for checking for vitamin D levels in patients. And the one thing, though, keep in mind, though, if you're going to be tested for it, lots of times the insurance doesn't cover it. I know Medicare does not cover for screening, and insurance will not cover vitamins if you need supplements. And generally the supplements they get are heavy-duty vitamin D levels that they get. Now, vitamin D regulation, we're talking about calcitriol, is regulated by a number of different things, not just parathyroid hormone and the phosphate levels. There's a number of things that can influence it. So you'll notice here on this graph, it shows you the relationship between plasma calcium and calcitriol. If calcium levels are low, calcitriol formation increases. As calcium levels increase, it decreases. But again, it makes sense. If I already kind of told you that one of the jobs of calcitriol is to increase the absorption of calcium across the GI tract, if your blood calcium levels are low, it would make sense I would need more calcitriol. If your calcium levels are high, I don't need to keep absorbing it across the GI tract. Parathyroid hormone helps to regulate it. You saw it increase the activity of that 1-alpha hydroxylase, which is that last step involved in the formation of calcitriol, and it takes place in the kidney. Phosphate also plays a role. So if you go back here, lower phosphate favors the formation of active vitamin D. If your blood levels of phosphate are too elevated, you will not make the calcitriol. Other hormones can influence calcitriol formation. And just think logically, why would estrogen increase calcitriol formation? So I'm saying estrogen increases it, prolactin increases, and growth hormone also increases it. When people think, well, estrogen and even prolactin, they're starting to think a woman's pregnant or breastfeeding. You're going to need more calcium in order to breastfeed, to prevent your breakdown if you're breastfeeding, breakdown of your bone to maintain blood calcium levels. Think estrogen in puberty. It's involved in bone growth. So you need calcium for that. Growth hormone is a general hormone in overall growth, including bones. So you're going to want to make sure you have more calcium around. So let's make more calcitriol so it can absorb more calcium across the GI tract. So there's a number of different things that can influence calcitriol formation. Now overall, the effects, before we kind of look at each step here, the biggest, hands down, the biggest effect of vitamin D is on the GI tract. Okay? Overall, though, if I say vitamin D effects, its overall effects is to increase calcium and increase phosphate in the extracellular fluid. Okay? In the GI tract, you saw earlier, it increases calcium binding proteins in the calcium pump. It allows us to increase the absorption of calcium. But it also increases phosphate absorption. Kind of calcium is a mediator for phosphate absorption. You can think again, opposites attract. So in the GI tract, it increases both calcium and phosphate absorption. In the bone, when we talk about bone, large amounts of vitamin D will promote absorption of calcium. And I should say resorption. So large amounts of vitamin D, you'll resorb bones because it increases the transport of calcium through the membranes. Small amounts of vitamin D more promotes calcification or bone accretion. The exact mechanism behind that, I'm not very familiar with. So it can, depending on the levels of vitamin D, it can promote accretion or resorption. So we're just going to kind of leave it there. In the kidney, it has weak effects. The effects in the kidney are weak, but they do increase calcium reabsorption. They increase phosphate reabsorption in the kidney. So those are kind of its effects in the kidney, kind of relatively weak. Biggest effects are in the GI tract. But overall, as an end result of vitamin D, is calcium levels increase. but it also increases phosphate. But just think about mainly its effects on calcium. Those are the effects of vitamin D. Way to kind of, so it won't be maybe less confusing later on when we compare parathyroid hormone versus vitamin D, is you think of vitamin D, major effects in the GI tract is to bring in calcium, but it also attracts phosphate. It's an absorption protein. So both calcium and phosphate are going to go up. Think about growing kids need to promote bone growth. They need calcium, but they're also going to need phosphate as part of that mineral component of the bone. So you just kind of put it that way. Think of it that way. That vitamin D, you want both calcium and phosphate to be up so you can promote bone. And you don't need a heck of a lot of vitamin D to do that, but just a certain amount of it. Now before I go on, I always forget this. Vitamin D is a hormone. I do have the picture in your notes. I didn't put it in the PowerPoint. Vitamin D, we did mention, is derived from cholesterol. It is a hormone that behaves like a steroid hormone, but it's not a steroid hormone. It behaves in that its receptor is found within inside the cell because the vitamin D can cross the membrane relatively easily. It's transported to the nucleus, where then it exerts its effects on gene transcription. The peak effects is going to take a few hours to days to see, so it takes a little bit longer to see the effects. Its structure, if you look at the structure of it, it definitely looks like it is lipophilic. But the main structure of it, it's not a steroid hormone because you have to have a centralized steroid nucleus. And I'll show you that during lecture time. But it's steroid-like, but it is not classified as a steroid hormone. And I'm going to tell you, Guyton has a mistake in the book where they do have listing of various hormones and said it's a steroid, and it is not a steroid hormone. All right, so here, this also kind of goes through the overall effects, so you can have it in case you missed it. Increases phosphate and calcium absorption in the GI tract. Stimulates bone resorption along with parathyroid hormone. Small amounts is needed for accretion. It also decreases excretion of calcium and phosphate. That's just another way of saying it increases the reabsorption. Okay, so it's just, excretion means it's going to be in your urine. So less is going to appear in the urine if vitamin D is around. Okay? Now let's move on to parathyroid hormone. Parathyroid hormone is made by the parathyroid glands, and most people have 4 parathyroid glands, which are on the posterior aspect of the thyroid. So they're kind of right near embedded within the thyroid gland. So if you look here are the thyroid follicles, and you'll notice right here, here's the thyroid gland, and here is the actual parathyroid gland. And we're zooming in, looking at the parathyroid gland, and you have various cell types in there. And the cells, most of the cells are making parathyroid gland, okay? Or parathyroid hormone, okay? Now, thinking about where the parathyroid glands are located, kind of like they're tiny little organs that are right on the back aspect of that thyroid gland. If someone has their thyroid gland removed, very important they leave one or part of the parathyroid glands because it's going to be very important in calcium maintenance. Sometimes the parathyroid glands are damaged in the process of doing thyroid surgery. Years and years and years ago, before they even knew what these parathyroid glands did, they had people who died following thyroid surgery because of issues with calcium balance, because they accidentally removed the parathyroid glands because they didn't know what they were and they probably missed them. But nowadays, they make very conscious effort of trying to keep the parathyroid glands around and try not to damage it. So that's something they monitor, is after following thyroid surgery, that they did not accidentally get damaged. Now the hormone, the synthesis and control, main is made by the chief cells. You don't have to memorize that. It's okay that you don't know the chief cells. But there's a number of steps involved in the synthesis, and you don't have to memorize this little picture. But I want to kind of discuss what is the major stimulus for this to be produced. It's actually produced initially as a pre-prohormone through a number of processes. You're going to remove a few amino acids and a few more amino acids, and it starts to assemble in its proper three-dimensional form and then secreted into the blood. Now, the hormone itself it's a polypeptide hormone. It's about 80-something amino acids long. When it's in the blood, its half-life is only about 3 to 5 minutes. It doesn't last a long period of time. And believe it or not, in the peripheral circulation, it can be cleaved into two fragments. The end part, the N-terminal fragment, retains the activity. It's about 30-something amino acids long. And they can measure in the blood that, but also if they do tests, they'll put, say, intact parathyroid hormone, and they'll put a little I in front of the PTH for intact parathyroid hormone. But both of them are going to be active in the bloodstream. But what stimulates the secretion of parathyroid hormone? Along the cell, you have sensors, receptors that sense or detect calcium. These receptors are actually G protein coupled receptors that work through cyclic AMP, that if blood calcium levels are too low, they're going to sense that, send the information into the cell, and tell the cell to start producing more parathyroid hormone. So low blood calcium, and to emphasize again, it's the low extracellular fluid levels of calcium, and of that, it's the ionized calcium. If that is low, you start producing more parathyroid hormone. So parathyroid hormone secretion, the stimuli for it is humoral, changes in calcium levels. There's no hormone that's involved in the increased secretion of parathyroid hormone. There's no neural stimuli. It's humoral. Now here, when parathyroid hormone is released in the bloodstream, it has effects on the kidney, the bone, as well as the intestine. Okay? So we're going to go over the major effects. Well, biggest effect, one of the major effects it has is on the bone. Here's my little osteoclast. It stimulates osteoclasts to release free calcium. Remember, we do have some calcium that is free. It's just like a readily available pool of free calcium within the bone, but it also will stimulate the breakdown of bone, or we say it favors bone resorption. It's a little more complicated than that. Overall, the osteoclast, the activity will be increased. It is. But it's only increased in response to the osteoblast sending a signal to the osteoclast to become more active. So the receptor for parathyroid hormone is actually within the osteoblast. When it binds to its receptor within the osteoblast releases a signaling molecule that causes the activity of the osteoclast to increase. Don't confuse the fact that if I ask you a question, what is the result of parathyroid hormone, and I list increased osteoblast activity, increased osteoclast activity, that you pick osteoclast. The osteoblasts are more active because they're involved in bone accretion. They're just producing a factor that's going to stimulate osteoclasts. So overall, the osteoclasts are more active. You break down bone, release free ionized calcium into the blood. Parathyroid hormone also increases the reabsorption of calcium in the kidney. So it's going to affect certain parts of the nephron tubule and allow you to reabsorb more calcium. Also, through its effects on vitamin D, it increases the rate of intestinal absorption. But it's mainly through its effects on vitamin D. Because remember, in the kidneys, parathyroid hormone stimulates the formation of calcitonin. So calcitonin is the one that's really increasing the absorption of calcium across the GI tract. So it's parathyroid hormone with the calcitonin that increases the intestinal absorption of calcium. But what it also does, I'm going to go back. So this is its effects on calcium, but I do want to mention parathyroid hormone's effects on phosphate in the kidney. In the kidney, parathyroid hormone increases the excretion of phosphate. You do not, any phosphate that you're reabsorbing, you don't want to reabsorb a lot of it when parathyroid hormone is around. So this is a little bit different than we talked about vitamin D. In the kidneys, vitamin D increased both calcium and phosphate reabsorption. In the kidneys, parathyroid hormone increases calcium reabsorption, but it does not increase phosphate reabsorption. So think of it this way. Major stimulus or role of parathyroid hormone, that is going to be released if your blood calcium levels are getting low. So it's like, I need to get my calcium levels back up, otherwise we're going to have problems. And remember, we don't want huge amounts of parathyroid hormone all the time because you'd break down bone and you'd have bone pathology. So it says, if parathyroid hormone's around, it says, I need to get my calcium levels back up. Free calcium levels back up. You don't want phosphate around also because it will complex with the calcium and it defeats the whole purpose. I want free ionized calcium. So realize, if parathyroid hormone's around, you might be breaking down the bone. And when you break down bone, you're going to have both phosphate and calcium released into the blood. I want to keep the free ionized calcium around, get rid of the phosphate. So when you hit to the level of the kidneys, the calcium that's filtered, let's take it back up, but let's leave the phosphate and let us excrete it in the urine. When you think about vitamin D mainly is something you want to have around normally all the time because you need to absorb the calcium across the GI tract. Small amounts, I want to favor bone formation. Because also it's going to favor a little more phosphate, a little calcium, but physiologic. Think physiologically. So a lot of students have problems grasping the fact that parathyroid hormone and vitamin D have different effects in regards to phosphate. But think about when they're needed. Parathyroid hormone is needed more when you've got issues and that your calcium levels are getting too low. Now the last hormone that we're going to talk about that's a calciotropic hormone is calcitonin. Now remember the picture when we did the thyroid hormone lecture. These here are the parafollicular cells or the C cells that produce calcitonin. Here's where you see it also. So calcitonin is made by the thyroid gland. This is a very small hormone. It's a peptide hormone. It's only about 30-something amino acids. It's released when blood calcium levels are really high. Okay? It's a relatively short half-life. But before I go on, in a normal adult individual, calcitonin does not appear to play a significant physiologic role in maintaining blood calcium levels. It appears to play more of a role if they say in development, early development in children, because it's going to be needed for make sure you don't have too much calcium around. But it does not appear to play a huge role in a normal adult. And I've listed some reasons that back that up. If you remove the thyroid from an individual, they replace them with thyroid hormones, but they never replace them with calcitonin, because you remove the thyroid, you're going to be removing the cells that make calcitonin. They never have to replace calcitonin, and they have no problems with calcium balance, of course, unless they damage the parathyroid glands. But we're just talking about the thyroid. There's tumors that produce calcitonin, but these patients don't appear to have problems with calcium balance. Okay. But calcitonin can be used in a clinical setting to treat some bone disorders. If someone has life-threatening hypercalcemia, they can administer a drug that is pretty much calcitonin, and actually they give them salmon calcitonin, which I think is interesting. So I think I'll have to look it up. Never mind, I won't tell you now. But calcitonin, although it doesn't play a role in normal adults, I do want to say what it does, especially if they're going to give someone calcitonin under life-threatening conditions. This is what it's going to be doing. But also remember, it plays a role mainly in adolescence. It's going to kind of have the opposite effects that you saw with parathyroid hormone. So I don't have these ones filled in, but we'll fill them in. In the intestine, you're going to have decreased absorption of calcium, because when calcitonin is high, you're going to have less parathyroid hormone. It's mainly, and therefore you have less calcitriol. So when calcitonin levels are up, you have a decreased absorption of calcium across the GI tract. It inhibits osteoclasts. The osteoblast, here my little osteoblast, will continue to lock calcium and put it into the bone, because you're going to have high blood calcium. Let's lock it in the bone. Let's move it in the bone. Let's not break down any bones, otherwise my calcium levels will go back up. At the level of the kidneys, it is going to allow calcium loss, or you can say any calcium that is filtered, we're not going to reabsorb as much. So it's going to promote excretion of calcium by the kidney. So overall, calcitonin will be released in response to very high calcium levels. Its job is to get the calcium levels back down, either by getting rid of it in the urine, making sure we don't absorb it across the GI tract, and locking it into the bone and making sure we don't break down bone. So that's the effects of calcitonin. I have a question for you. Some of you may know the answer, some not, depending on when you had lab. If you have someone that is osteoporotic, can you give them calcitonin? And they actually say in some instances they've been given calcitonin to people with osteoporosis. But it's not very often. It's not very common, because it doesn't appear it has a huge dramatic effect. It's going to have very limited effects. And the way we're going to illustrate it for you is in lab, where you have an osteoporotic female, where they're going to administer calcitonin. They're going to administer estradiol. or they won't give her anything. And the one that has the biggest effects is estradiol, because of estradiol's effects on bone. And one of the things that people worry about, or women that go through menopause, is the loss in bone, because estradiol does affect bone formation, and it inhibits the breakdown of bone. So they decide whether or not they're going to do hormone replacement therapy. So that's a discussion for a later point, but it's something to think about. But one thing, though, that when calcitonin is not given very much, if at all, to women with osteoporosis, because it has very limited effects. So we're going to stop here, and I will have another webinar that will propose to you various clinical scenarios to help you in trying to work through calcium and phosphate homeostasis, the role of parathyroid hormone, the role of vitamin D, and I'm really not going to go into calcitonin, but those role in the calcium maintenance.